So, 10-year-old boy presented to emergency with 3-day history of polyuria, polydipsia, and fatigue. Noted increased irritability and confusion over past 24 hours. There was history of recent respiratory illness, treated with over-the-counter medication. Examination: weight 30 kilos, heart rate 130, BP 90/60, RR 30, GCS 13/15. There was abdominal tenderness, but no guarding and rigidity. There was sign of dehydration, dry mucous membrane, and decreased skin turgor. Blood glucose 29, serum ketone is positive, ABG 7.2, bicarb 15, and NGAP 18. Electrolyte 130, potassium 5.5. Okay. So, what's the most likely diagnosis for that scenario?
29.
Ketone was positive, bicarb 50. So, DKA?
Yeah. So, what are the primary metabolic derangements seen in the DKA?
The glucose,
Okay.
high elevated serum glucose, ketone, high anion gap,
Okay.
and he's also in respiratory, acidotic breathing.
Okay, so the pathophysiology of DKA. It's still general pediatrics, nothing subspecialty about this. I know it's endocrine problems, but you are expected to know and manage this kind of problem lah. I was in SP, DKA come every month.
High serum glucose, because high insulin, and with high serum glucose causing high potassium because of the cell damage, and because of the cell damage and acidosis causing the acidotic breathing and GCS to drop.
But that doesn't explain the pathophysiology. So the main cause why a patient have high glucose is because of what?
Because of the impaired insulin metabolism.
Is it really impact insulin metabolism?
It's high because of the high serum insulin.
No. So DKA in children, especially type 1. So are the primary cause of this thing?
Decreased insulin production.
Because of what?
Because of the mutation of.
Is it mutation?
It's a damage of
So
the pancreas.
so the destruction because of what?
Destruction because of
So autoimmune lah, right? Yeah. So there is autoantibodies lah against the pancreas.
yeah.
Alright. So if you send investigation specifically for the autoantibodies, what autoantibodies would you send?
Autoantibody. Autoantibody tu bisa.
Tak ingat.
Aku ingat betul.
Okay, so in this clinical presentation, what are the key clinical signs and symptoms of DKA in this child?
Initial sign and symptom is the confusion, polyuria, polydipsia, and rapid breathing, confusion dengan he have
He also has what?
abdominal distension.
Okay. Then other symptoms?
Other symptoms
Dapat tak history tadi? Bagi.
I dapat polyuria, polydipsia, confusion, respiratory illness preceding the event.
Okay. So the clinical presentation is the polyuria, polydipsia, fatigue, and increased irritability and confusion lah. Okay, so the trigger is
the respiratory illness.
Okay, alright. But when patient has DKA, mean the destruction of the pancreas has been happening for the past few months already. Okay, so when there is illness, when there is increased requirement of insulin, when you are sick, your sugar level will be high because stress reaction. So when unable to compensate for that stress reaction, that's when the DKA comes lah. Okay, but when the DKA happen, meaning your pancreas is not, basically most of the pancreas function is already destroyed. So there was a period memang the processes has been going on, the destruction process has been going on for the past few months lah. And the symptom usually will start slowly lah. So usually the symptom of DKA, what do they present with?
Polyuria, polydipsia.
Okay, sama.
And then like if younger kid, like bedwetting, frequent urination at night, loss of weight, loss of weight, irritability, confusion is already towards the end.
Okay, so what are the more worrying signs this patient?
The abdominal tenderness with the low BP.
No, low BP, okay. Alright, but maybe we have some dehydration, a bit of lowish BP. What about more important signs during the examination finding that I provided you just now?
Tachycardia.
No.
The tachypneic RR of 30.
And what part of the DKA symptoms? Because you are acidotic, what?
Shivering.
What about the GCS?
For GCS of 13.
So GCS is borderline like that. What are you worried about?
Patient will go into cerebral edema.
Yes, cerebral edema lah. Okay. What are the risk factor for developing cerebral edema in DKA, pediatric DKA?
Fluid. They give too much of fluid, excessive fluid correction.
Okay.
And very rapid fluid correction.
Okay. Some more.
And then electrolyte imbalance.
Okay. Which electrolyte specifically? Sodium. So what about the sodium?
Too fast correcting the sodium worsens the cerebral edema.
Are you sure? Too fast The sodium is 130 in this patient. Okay. So I provided you the lab result, right? So sodium is 130. Sugar is 29. What is the corrected sodium for this patient? So you need to find out this whole hyponatremia. Is it because of hyperglycemia effect? Okay. So you need to basically make sure it's not pseudo hyponatremia first. Okay. Alright. When the blood glucose has been reduced slowly, even after you give drips, the sugar will come down slowly as well. Okay, but the sodium, after corrected sodium, still remains low. You need to push up the
concentration of sodium.
Yes, because hyponatremia, the true hyponatremia, predispose patient to cerebral edema. Now, if you keep the sodium low like that, your osmolality is basically hypo lah compared to in the blood. Alright, so hypoosmolar, so dia akan fluid shift lah to the brain. So that's why if you see hyponatremia persistent, those are predisposing factors for child to develop cerebral edema. So that's why I think the teaching is always to push up the sodium concentration to correct the sodium. At least it's steady level lah, not going down level. If you're going down, you have to push up. Okay, alright. That's another risk factors lah. If you remain patient remain hyponatremic, that's one thing. You correct to fast fluid also can. What else?
The potassium was 5.5.
Potassium is nothing. No, it won't cause cerebral edema per se. So what are other treatment you provided can predispose patient to develop cerebral edema?
No, other than fluids.
Sometimes they always love to give what in patient metabolic acidosis.
Bicap.
Yes, you give bicap. That's another reason for developing cerebral edema. So in DKA, don't ever give bicap. Okay, those are basically the important pointers you need to basically remember when you treating patient with DKA. But I always emphasize on the sodium. Always chase the sodium level. Okay. And then because I think endocrine here they are quite they target the sodium level to be higher lah. Okay. So, okay, if patient you already established DKA diagnosis, how you want to treat?
Diabetic education.
No, during the DKA, the acute DKA part.
Okay. That means after stabilize.
No, like during when patient come to emergency, what you want to give first step first?
First is fluid. Then 1 hour later is when I'll start the insulin. Then repeat blood gas with sugar every.
So, what are the difference between adult managing DKA and peds managing DKA?
We don't give the insulin directly. We start 1 hour after the hydration.
1 hour, 2 hours doesn't matter lah. So the first point is we always fluid bolus first, treat the dehydration first. Okay, then baru start insulin. Okay, because by doing that alone, your sugar level will come down. Okay, right. Okay, continue. So give fluids, then start insulin.
And then the patient nail balm out, GCS chatting, and monitor the urine ketone.
Okay.
Then to start the insulin according to the sliding scale. Respiration. If able to maintain the oxygen, then we can put supplementary oxygen only. Keep nail balm out and strict IO charting.
So why we need to keep them MBM?
In case the GCS deteriorate, then we want to intubate and easier glucose conversion when we just come from drip.
So if patient have full GCS, do you still keep them MBM?
Until yes, actually
Why?
I feel easier for glucose conversion when we just come from drip.
Okay.
And the drug perfusion.
Okay, but if you decided to give MBM, what will happen? If you decided to allow them orally, what will happen? During the DKA are still very high, sugar very high, acidosis, very bad acidosis.
Patient might develop vomiting with higher sugar level then.
Is it sugar? Or is it something else?
Ketosis.
Ketosis lah. Patient will not able to tolerate orally lah. That's why we keep them MBM until the ketone level has reduced to less than 1 at least, or better still trace or negative. Then baru you makan. Okay. Most of the ketosis patient will be nauseous and vomiting lah, on top of your other reason just now lah. Okay. So the potential complication other than cerebral edema, what else? So what are the electrolyte abnormalities you expect when you're managing? Other than hyponatremia or hyperkalemia. So what about the hyperkalemia? Is it truly hyperkalemia or is it hypo? Or can both be present?
Because of the dehydration.
Okay.
Yes,
To indicate the initial part, there will be hyper K. Once you start giving insulin, and hypokalemia will set in.
Yeah. because
Alright.
of insulin.
So that's why sometimes you probably just no need to treat the hyper K lah. If still within the range or just slightly raised. Once you start insulin, it probably will improve lah. So on top of hypo K, hyponet, what else can happen? What other electrolyte can be involved?
Potassium. Phosphate.
Phosphate. What about phosphate?
Phosphate will be high. Yeah, phosphate will be low.
Phosphate will be low. Okay. So kalau flu nak buat apa?
We can supplement in the We can supplement it in the drip.
Okay. Alright. So ada complication? If you start insulin, what other complication can happen?
And the potassium. Hypoglycemia because
Hypoglycemia lah. Okay. So kalau hypoglycemia, dia punya management strategi apa kalau nak buat?
Reduce the insulin load and
Okay.
yeah,
Ada jalan reduce insulin rate?
increase the concentration of dextrosity in the drip.
Okay lah. Those are the two main thing lah. Okay. Alright. Then so bila nak convert?
Once ketone reach 0.
Okay. Ada than that?
And patient is not asymptomatic. Patient is well. He can he doesn't have nausea.
Other than ketone, what other criteria you can use? What do we monitor?
The glucose.
More? Glucose will be low high lah. Okay. But that's not the other than ketone.
The pH.
pH lah, the pH level lah. Once the acidosis improving or resolving, then you can start converting lah. Okay. So once patient dah already out of DKA, so how you want to educate the family to prevent future episode of DKA?
For insulin conversion based on meal and to provide sick day insulin regime and to check urine ketone during unwell period and if despite being on sick day regime urine ketone present to come to hospital immediately.
Okay. Not competent enough. Okay, so I tanya out of the blue je. Tapi you should know it's general pediatrics. You all MOs already now, houseman. Mesti lagi lah kena tahu. Sekali. Tak pernah manage DKA per se? Pernah. Then you manage for once, so probably you can remember a lot already. Okay.